Okay. Just a couple more people coming in, but we are going to get started because I know there's a lot of really great content that is going to be covered today. So good afternoon, everyone. Welcome to today's Lunch and Learn session. My name's Emily Shandrick, and I'm a program and education coordinator at the Center for Education and Research on Aging and Health. We would like to begin by acknowledging that Lakehead University is located on the traditional lands of Indigenous people. Lakehead Thunder Bay is located on the traditional lands of the Fort William First Nation, signatory to the Robinson Superior Treaty of 1850. At our center, we are committed to working towards reconciliation and decolonizing our work, and have committed to as a staff to educating ourselves in these areas, both personally and professionally. For myself, as a treaty land inhabitant, I'm committed to ongoing learning and reflection on the history and legacy of colonialism. I'm also committed to supporting change movements and education led by Indigenous people, and the ongoing process of establishing and maintaining respectful relationships. Our Lunch and Learn topic today was chosen purposefully as a way of supporting National Advanced Care Planning Day, which is coming up this Saturday, April 16th. The theme this year is Life Happens, Be Ready, which you can see with Jill's beautiful background. We're very pleased to have Jill Marcella here today, a regional champion for advanced care planning and healthcare consent with Hospice Palliative Care Ontario. We called this session part 2 because Jill did a similar presentation last year with a lot of interest. Jill will be answering some frequently asked questions, and we have some questions that were sent in from some in past attendance. For any questions that may not be able to be answered within the hour, we can follow up with those answers. So just before we get started, just a little bit of housekeeping for our session today is that, again, this presentation is being recorded and will be added to the Sarah Education archives on our website. We do ask that you stay on mute. If you have a question for Jill, you can use the chat function, which is just right there. And you can also raise your hand using the reactions, which is kind of over there. And you can raise your hand and we will gladly unmute you and let you ask your question verbally. We will also send out a copy of Jill's slides after the presentation today as a resource. So I'd like to go ahead and introduce Jill at this time, whom many of you probably know. So Jill Marcella is the manager for the Northwest Regional Palliative Care Program with St. Joseph's Care Group. Jill is a registered social worker with a specialization in gerontology, with work experience that has included community and long-term care. Her role focuses on working with system partners, healthcare providers, clients, and families in planning for and creating a coordinated system of palliative care accessible to all individuals living with a life-limiting or terminal illness, wherever the individual lives. So please join me in welcoming Jill, and thank you for being here.
Thank you so much for the introduction and the lovely land acknowledgement. So yes, this year's National Advanced Care Planning Day, Life Happens, Be Ready, is the theme. And the Regional Palliative Care Program likes to collaborate with the Center for Education and Research on Aging and Health every year to try and deliver a presentation that can be offered in acknowledgement of National Advanced Care Planning Day. So we thought we would do a little bit of a repeat of last year. I have to state my bias. I'm very passionate about advanced care planning. So I can often talk an awful lot about it. And I really do try to keep the content concise and to what's very relevant, but there's a lot of content. So today's talk is really trying to focus on advanced care planning, but recognizing that advanced care planning, goals of care, healthcare consent, they all kind of intersect at some point in time. So it's getting an understanding of where these conversations and when these conversations are being had and what it is we're talking about when we are engaging in the different types of conversations. So I'm just going to share my screen and we'll get started. So as I said, there is a lot of content, but don't worry about taking notes because the presentation will be sent out and the answers to the questions that will just be highlighted on the slide will actually be included on the slide as well of the version that you receive. So today is really looking at having an opportunity when we've presented, and I've presented in the past around advanced care planning and healthcare consent, a lot of questions come up. So we've been kind of collecting some of these frequently asked questions and then decided, well, why not just have a presentation that responds to those questions? So we're really just wanting to, in addition to increasing your awareness to advanced care planning and some of the common misconceptions, also provide answers to some of those frequently or commonly asked questions that we receive. So I like to start with just clarifying some of our confusing terminology. And you'll often see that some of these terms are used quite interchangeably, but we like to recognize that in Ontario, so in Ontario on the left-hand side of the screen there, these are terms that are actually aligned with the Ontario law. And on the right-hand side of the screen are terms that are not aligned with our Ontario law, but are often used. So advanced care planning, living will, advanced directive. Currently in Ontario, we do not have living wills or advanced directives, although many people do complete them. Other provinces do have these documents and can take them as consent, but this is not the case in Ontario. So healthcare decisions are made by a person and not a piece of paper. So the terms are not legally defined in Ontario law. But they are heard in common language and they are borrowed from other jurisdictions, countries, and provinces. So the use of this terminology can sometimes cause some confusion, and it can also be a misrepresentation of the Healthcare Consent Act or Advanced Care Planning or even the Substitute Decision Makers Act as well. So we just like to raise awareness to that. And also we know, I know myself, even in our own electronic medical record or EMR at the hospital, in Meditech, advanced directives is an intervention that is labeled within the EMR. So recognizing that even within our own systems and processes, we're often using terminology that doesn't align with Ontario law. So just to get an understanding, this slide really illustrates some of the key terms in Ontario and how they work together. So as a process, and again, advanced care planning really is a process. It involves conversations with the person while they're mentally capable and really about sharing their values and wishes with their substitute decision maker. And this can happen at any point in life. The earlier, the better. And I know for myself, when my oldest turned 16 and was beginning to drive, that was the first opportunity that I took to have some conversations with him about what he values and what's important to him, because as a young driver, accidents can happen at any time, unexpectedly, and I really just wanted to start that conversation with him. So advanced care planning conversations inform the goals of care discussions that may come at a later point in the context of an individual's current illness. So the ideas that are discussed may help decide what sorts of treatment may or may not be wanted as that individual's condition progresses or the situation changes. And then finally, any conversations where we're seeking consent from the healthcare provider, these are really consent for treatment or care decisions that are being made. They're not advanced care planning, part of an advanced care planning conversation. So quite simply, there are really just two parts to advanced care planning in Ontario. The first part is really confirming your substitute decision maker, identifying who that individual is, and confirming that that is the person that you would want to be making decisions for you if they were asked and you were not mentally capable to make that decision yourself. And the second part is really those conversations that you're going to be having with your substitute decision maker, with your family, or with your healthcare provider around what's important to you. And those conversations are really informing and guiding your substitute decision maker in the event that they have to be making a decision in the future. So when is it relevant? Well, as I mentioned, advanced care planning is relevant when you are incapable. It becomes relevant when you are incapable of making your own health decision. And your substitute decision maker can use the information that they've had in those conversations to guide your care, advocate for your wishes, and consent or refuse to treatment that might be being proposed. So often we get asked if, advanced care planning, it's a document, it needs to be recorded, it needs to be written down. Is it an official document? And the answer is no. Advanced care planning does not have to be written down. It can be recorded. It doesn't have, and if the person would like to have that to guide their substitute decision maker, it can be written, it can be video recorded, it could be audio recorded if you wanted, but it doesn't have to be a document. Can advanced care planning decisions and directions simply be verbal? And the answer to that is yes. So it really is those conversations you're having with your substitute decision maker, letting them know what's important to you, your values, things that you want or don't want, and that can be in the way of a verbal conversation. And as I mentioned, it can be recorded through audio, video, or electronically. So what is a substitute decision maker? And before we begin, I just want to ask everybody, and I don't know if you can say a thumbs up or just put it in the chat box, but do you, those of you who are joining us today, do you know who your automatic substitute decision maker is? So just think about that. And we'll go on to the next slide to see I've got some thumbs up. Great. So every person in Ontario has an automatic substitute decision maker, even if they haven't appointed one. So the substitute decision maker is the person or persons who provide informed consent to treatment on the behalf of the person who has been deemed incapable. Personal care in the Substitute Decision Act. So it's healthcare decisions, but it's also personal care decisions. So it covers healthcare, nutrition, shelter, clothing, hygiene, and safety. So it really is the ability, giving them the ability and authority to make decisions in all of those areas. And they're the decisions that are governed by the Healthcare Consent Act. So those are the treatments that are defined under the Healthcare Consent Act. Admission into a long-term, it includes admission into a long-term care home. And it also includes personal assistance services in a long-term care or retirement home or community. How does this role differ from a power of attorney for personal care? So the power of attorney for personal care is a type of substitute decision maker, and it is one that is appointed by the capable individual, and it is giving them the same authority as giving them the authority to be a substitute decision maker. So this is our hierarchy in Ontario of the substitute decision makers. So as you can see, and I really like this model that can be, you can get it off the Hospice Palliative Care Ontario's, Speak Up Ontario website. So those first three substitute decision makers that are in yellow, those are legally appointed substitute decision makers. And then the green are what are our automatic substitute decision makers. And they are ranked in hierarchy. And then the substitute decision maker of last resort is the public guardian and trustee. So reflecting back on the question that I asked with the previous slide, do you know who your substitute decision maker is? Have they fallen within that hierarchy, and are they in the right place of the hierarchy if that is the individual that you think is your substitute decision maker? So before I go to the next slide, there's a description of what each of these roles are. And I think in healthcare, quite often, we sometimes come into trouble when there are multiple substitute decision makers. So to be a substitute decision maker, they have to be the highest ranking on the hierarchy. They have to be at least 16 years of age. They can't be prohibited by law or a court order or separation agreement to act as your substitute decision maker. They also have to be available and willing to assume the responsibility of giving or refusing consent. So this is a voluntary role. And even if you've appointed someone through a power of attorney for personal care, at some point in time, if that individual chooses that they no longer want to be the appointed substitute decision maker, they can withdraw from that process. So I'm just going to ask if any of you, if you'd like to share, if anyone would like to share, have you ever been in a situation where maybe there has been some challenges around the substitute decision maker confusion because you've had maybe multiple substitute decision makers in one row? And if there's an example that you'd like to share how this can be problematic. We have a quiet group.
There's one comment in the chat there, Jill. I don't know if you saw it.
Oh, thank you. I can't, sorry, I don't have the chat. So
that's okay. Someone just
conflicting
saying,
views. So someone's saying conflicting views. Yes, yes. So that's where we can really have some challenges, because if there's multiple children and they're all the substitute decision maker, because under the hierarchy, if you have 4 children and you haven't appointed someone, then all 4 children would be needing to be consenting to whatever was being proposed. And often multiple children might have multiple understandings of the illness of the person, what those previous wishes from that individual might have been. Maybe there were separate conversations. Their understanding of what the treatment is that's being proposed and what the benefits or risks are. So there can often be misunderstanding, and the healthcare provider, we can't just get consent from the person who's going to, or the individuals who are going to agree with what we're proposing. So if you have 4 children and 2 of them agree with what's being proposed, or 3 of them agree with what's being proposed and 1 does not, that is not consent. They all have to agree, unless amongst them they've come to some agreement that there will be a spokesperson who will speak for the group, or one of the children have removed themselves from the decision-making process and they've said, I'm not interested in being the substitute decision maker, I want my siblings to be. So I see here an example of have an uncle, Michelle, thank you, in the ICU, and the spouse had died and his 11 children had to decide to discontinue the life support, and it was very conflicted and there were various positions, and the process took a month or longer, and I could really see how that's can easily happen. That's a lot of people that are having to make a really, really significant decision for an individual. And in those cases, our emotions are often brought into the decision-making process. And of course, family and decision makers are often coming from a place of love and not wanting to let someone go. So they may be making those decisions based on their own needs or their own values, without necessarily taking into consideration or really listening to what that individual may have previously expressed. And yes, with the healthcare perspective, at times this can conflict within extended family decision-making processes, and you can reflect on a few times where this has been challenging. So it's not an easy situation. So that's one of the reasons these conversations are so important. If nothing else, just to be talking about the role of the substitute decision maker, who they are, and whether or not they're going to actually listen to what it is you want them to do. And that's sometimes often what I will start with. I think when these conversations can be difficult and challenging, and when we go into them, and the easy intro is, do you know who your substitute decision maker is? This is the person that if something were to happen to you, and you were unconscious or maybe not capable for a period of time, this person is going to make decisions for you. And sometimes I'll hear people say, oh, yes, I know. And that it's my wife and it's fine. And I'll ask, and have you had conversations with your wife about the things that you would want or not want to happen? And then sometimes I hear back, well, they know what I want or don't want. So lots of opportunities, I think, where we can open up some dialogue when we're working with clients or family members to start getting them to think about some of those things that they might want to be sharing with their substitute decision maker. So what happens if I'm separated? I get this one quite a bit, but I'm still legally married. Is my ex still my legal SDM? So when you're separated but legally married, my first question would be, did you have a will that was completed with a power of attorney for personal care as part of that? Or do you already have an existing power of attorney for personal care document? If the answer is yes, and that spouse has been named as your substitute decision maker, then they would still be able to make those decisions if you haven't changed that legal document yet. If you don't have a power of attorney for personal care and your ex is named and they're just that person on the hierarchy and you're separated, they would not. So two persons who are not considered spouses if they are living separate and apart because of the breakdown in their relationship. So if you haven't got a document that has appointed him or her as your SDM, then you don't have to worry about it. If you do, you want to tell the person to make sure that they change that document or fill out a new power of attorney for personal care so that the old one can become null and void. And where do stepchildren and step parents fit in? So this is a tricky question because in the Healthcare Consent Act, it doesn't explicitly address this scenario. So since it's not addressed, it could be argued that the stepchildren and step parents fall on the parents and children line level of the hierarchy. And so this can bring in some complexity and make the family situation a bit complicated if there is tension within that family between those roles. So again, an opportunity to talk about who's considered, where they are in the hierarchy, and is the individual okay with all of these people potentially making decisions for him or her. So another one that we often get is, can my doctor be my substitute decision maker, or can a healthcare provider be a substitute decision maker? So anyone who is paid to provide healthcare, residential, social training, or support services, and this would include a doctor, a landlord, or a social worker, may not be named as your substitute decision maker. So the answer to that is no, a doctor can't be your substitute decision maker. Unless, of course, the doctor happened to be your spouse, and then they would be. So another question that we often get is, where does the next of kin come in, and what control do they have over a person's decision making? So the next of kin is the closest living blood relative, and it can include spouses, adopted family members. And this is a designation, but it's not a term under the Healthcare Consent Act or the Substitute Decision Makers Act. And this is where we often in healthcare can have maybe potential confusion, because next of kin is often in referral forms, or it is noted in the electronic record of the individual. And sometimes people may actually look to a next of kin as thinking that that would be the person they would be contacting instead of the substitute decision maker. So it's really important that in our electronic records and in our paper records, for that matter, what we should be really capturing and making sure is highlighted is the name of the substitute decision maker. We can still have next of kin in there, but it needs to be, I think the substitute decision maker needs to be very prominent in those forms or in those electronic records. So another question is, whose direction should be followed when several family members are disagreeing about their loved one's care needs? So as we've talked already, if you have more than one person in the same care category that's available to act for you as a substitute decision maker, then all of them would act together and have to agree. Or as I said, they may pick as a group one person as a spokesperson, but that's been agreed upon within the group. They must agree in some way as to what the decision is for you and how many of them are active in the decision-making process. And as I said, healthcare providers can't just pick the decisions that might be the ones that we want to hear when there's a group of decision makers that we need to be getting consent from. Does my substitute decision maker have to live in Ontario? So no, your substitute decision maker doesn't have to live in Ontario. They can be located anywhere. The healthcare provider, they just need to be available and willing in some way. So not necessarily in person, as long as they're available by phone. It could be by telemonitoring or Skype, some way that allows them to communicate directly with the healthcare provider. And what if your substitute decision maker is not able or willing to make decisions for me? So the substitute decision maker role is voluntary, and a substitute decision maker has to be willing and able to take on this role. So if the person on the hierarchy is saying they're not willing or able, or if somebody that you've appointed in a power of attorney for personal care is refusing to act, then the healthcare provider would go to the next individual or individuals on the hierarchy line as they appear in the Healthcare Consent Act. So keep in mind that a substitute decision maker also can appoint, they can't appoint another substitute decision maker in their absence. Or they can't complete, your substitute decision maker cannot complete a power of attorney for personal care for someone else. And I have seen examples of this, particularly in long-term care, where the resident, the child of the resident was the substitute decision maker or the power of attorney for personal care, and then they were going to be wintering somewhere. Maybe they were going to Florida, or they were going down south to Mexico, and they would say to the staff, well, while I'm away, if there's anything that you need for consent, please contact, her granddaughter or his granddaughter or grandson. They live here in the city, and they'll be able to consent to anything. That substitute decision maker doesn't have the ability to do that. And as a healthcare provider, we would have to actually go to the next person on the line if we weren't able to get in touch with them while they were away. So sometimes just letting family know, and they're surprised, they are often surprised that they don't have that authority to appoint somebody else. So we have to often bring that to their attention. So does a patient's or person's written plan and wishes outweigh the decisions of a substitute decision maker if they can't speak for themselves or they're not capable? So as healthcare providers, we have to get informed consent from the person or the substitute decision maker. And as it's related to specific care or treatment that's being offered and related to their current health conditions. So wishes are not consent, and consent does not come from a document. So if there are no expressed wishes, then the substitute decision maker has to consider what that person's values and beliefs are. The substitute decision maker must try to make the same personal care choices or decisions that the person would make if they were capable and able in that given situation. So a written plan and wishes do not, they are what guides the substitute decision maker. So sometimes I've also seen this happen, and it can be very, it can cause distress for healthcare providers. When you know as a healthcare provider that there has been a written plan or there have been previously expressed wishes around certain treatments, and then the substitute decision maker, because the person's not capable, has to be making that decision. And the decision they're making actually is contradictory to what the person had expressed to you. So in those cases, they can be very challenging. And sometimes the healthcare provider, because they just don't want to be having arguments or kind of getting into discourse with the substitute decision maker, they will go along with what the substitute decision maker is consenting to, even though they know that it might not be what the individual wanted. But there is a process in those situations that we have as healthcare providers. So there really are two. We can involve the public guardian and trustee and reach out to them and let them know what's happening and ask them for some guidance. They may or may not get involved. When it comes to healthcare decisions, I find they're more reluctant to get involved and are often directing healthcare providers to find somebody on the substitute decision maker hierarchy or go through the consent and capacity board process. So that's the second option we have. We can involve the consent and capacity board to review the appointment of the representative. So the person who's the substitute decision maker, they can review the directions or the plan or the wishes that have been documented or that a healthcare provider has heard from the individual. And they can look at whether or not the substitute decision maker is departing from those wishes. And then they can actually make some decisions and determinations based on that. So we do have a process. I don't think it's often pursued by many healthcare providers, but the consent and capacity board is there to help us when those challenges like that come up. And the substitute decision maker isn't in making the decisions that have been previously expressed or taking those wishes into consideration. So often people think that there's a cost with advanced care plan or advanced care planning, and there is no cost with advanced care planning. These are conversations that are to occur with the individual, with their substitute decision maker. If you complete a power of attorney personal care document from the Ministry of the Attorney General, there's no cost to complete that document. If you go to a lawyer to have those done and they draw them up, then there will be costs associated with that. So often something else that seems to come up in advanced care planning conversations is around do not resuscitate and do not resuscitate orders. So advanced care planning isn't about DNR orders. A good rule of thumb, if we're having those conversations and that's actually what we're seeking as a healthcare provider, we're wanting that individual to consent to something, then we're not actually having an advanced care planning conversation. We're having, it could be a part of a goals of care conversation or it's a consent conversation. So unless you're facilitating the individual to complete a power of attorney for personal care document, that could be part of an advanced care planning conversation, but not a do not resuscitate order or DNR. And what can caregivers do when it is too late to fill out power of attorney paperwork? So the representatives, a caregiver can apply to the consent and capacity board if they're wanting to be a substitute decision maker and they're not on the hierarchy, or if it's something that hasn't happened and now the individual isn't capable and they are actually further down on the hierarchy, so they wouldn't be the automatic person, they can apply to the consent and capacity board to be appointed as a representative. So there is a process for that. And are there any Anishinaabe practices or traditions we can incorporate when discussing the matter with families? So this is really looking at the importance of the relationship and developing our relationships with the people that we're providing care for, as well as understanding the community from the person, where the person is coming from, and asking how that person identifies or relates to their cultural practices or traditions, how important they are to them. And it's also really important for us to be conscious of the language that we use, because as healthcare providers, many of the terms that we commonly use are either terms that aren't culturally appropriate for some people, or they're not terms that are part of their language. So they may very well not know what a substitute decision maker is or what that means and why that would be needed. And they may not know when we're talking about advanced care planning what that is. So just having an awareness of the language that we're using and how we describe things. And there have been, and I think it has been since last year, a really great resource that is here on the slide from Canadian Virtual Hospice that can really help with some of those conversations with Indigenous individuals that really are coming from a more culturally appropriate perspective. The questions that this resource was very intentionally created. And the questions in there have really been vetted by the individuals who created the document. So it is a great document to be able to use if you're wanting to start those conversations. And what about internet planning, such as things on Facebook, email, or some of those documents that you can get online? So it's a good idea to think about passwords and internet planning, such as Facebook and email, as well as the Apple ideas. Those can be part of an advanced care planning conversation, and just asking a person while they're thinking about those things, they want to be thinking also about that type of information and who might have that, who might have those passwords or where they might want to keep them. And there are some really good planning guides that are not advanced care planning guides, but they're really great as part of an advanced care planning process. A guide like the Don't Duck the Conversations, which can be, you can get through Hospice Northwest here in Thunder Bay. They have it online, and our program also has hard copies of that planning guide as well. And this doesn't have to be your power of attorney for personal care that's responsible for it. It's something that you would want to be doing to help that person, or the power of attorney for personal care or your substitute decision maker. So it's really a good idea with the second question, where should I store original copies of power of attorney documents or a planning guide like Don't Duck the Conversation. So that for the power of attorney documents for personal care, it's a good idea to make copies, and it's a good idea for your substitute decision maker and your loved one to have a copy. And note that often healthcare will accept a copy of the original. However, it's important that for the power of attorney for property, I'm not really talking about that today. Some of those Ministry of the Attorney General copies may not be accepted as adequate proof through financial institutions, and you may be asked for a certified copy. And then you really want to have a safe place to store these documents, because some of the information in it, particularly if it's anything around your planning, you're not going to want to have lying around in case other people might see it. So you want to have it stored in a safe place, or you want to have copies. And if you're giving them to your power of attorney or your substitute decision maker, you want to make sure that they're storing them in a safe place as well. So do you need a power of attorney for personal care? No, the short answer is no. We all have an automatic substitute decision maker, so it is not a requirement to have a power of attorney for personal care document completed if you're satisfied with who would be on the hierarchy to be making those decisions. So really, when we are appointing someone as a power of attorney for personal care, we want to remember that this individual or these individuals will be able to make decisions about where you live, what healthcare you get or won't get, what type of food you eat, the clothes you wear, and how your hygiene is maintained and what risks you can take. So it is a very powerful document for the power of attorney for personal care, as well as a lot of responsibility for the person who is the substitute decision maker. And how can you get these documents done? So as I said, the kits are available online through the Ministry of the Attorney General, and we've got the link in the slide. You can also look into, sometimes there are free legal clinics. Like I know that Lakehead University sometimes has some free legal clinics. They may be a source that you could go to if you do have maybe the financial burden of going to a lawyer is too much. Sometimes they might have clinics that are open. And I know even there's a group called Advocacy North who has helped individuals, typically it's older adults, fill out some of their power of attorney for personal care documents. And you can always go to a lawyer. So who is the best to discuss advanced care directives and power of attorney documents? I don't want to provide a legal advice out of scope. So this is a question from healthcare providers. So advanced care directives, again, are not legal terms in Ontario. So healthcare providers would not be taking up advanced care directives, but instead, if you were taking up any type of consent, you would be engaging in a consent conversation. And we can introduce power of attorney documents or information to individuals, but really it's ultimately up to the individual who is capable that's going to have to complete the document and get the witnesses. So how do you bring up this topic when the person doesn't want to know that they're palliative? So this was a good question, because advanced care planning doesn't mean that you are palliative. Unfortunately, I would say advanced care planning seems to have been kind of situated within the palliative care circle. But as I said earlier, it really is, as soon as you, these conversations can start at any time. And ideally, we're having them when we're well, not when we're sick. So because it's been associated with palliative care, it can sometimes be a challenge. And if the person doesn't want to talk about palliative care, then this is an opportunity for us to meet them where they're at. If we are wanting, this just happens to be the time, nobody else has had any of these conversations, and this happens to be the time that you're coming in and trying to have some of these conversations, it can be an opportunity for us to explore really what their illness understanding is, and really talk about the purpose of your visit or interaction, that it isn't about, getting consent from them, but it's really about having a conversation. And I just heard this week, Waterloo Wellington had an advanced care planning webinar, and they had a physician or doctor from the UK talking about advanced care planning, Dr. Catherine Mannix, and she really talked about looking at advanced care planning and understanding its confusion, and how do we go about, starting that conversation. And we get caught up on our own terms. But she really had a good analogy about, how to start. And she said, you think about when you're going on a trip, any trip, and how much you plan ahead for that trip. So if you're going on vacation, you're planning your flight, you're probably planning your hotel. And of course, there's individuals that don't want to plan at all. They're just going to arrive and they're going to see what happens and just take a risk. So there are those individuals who don't want to plan. They're just going to see what happens. And as healthcare providers, I think we get to work with both those kinds of individuals. There are those that we can support or maybe influence in having some of those conversations. And then there are others that are really not going to want to have any of that conversation, because if they think it really has to do with dying and death, and not that process. But even when they don't, we can confirm who their substitute decision maker is. And it really is, what are we talking about? We're talking about the person's goals. We're talking about what their fears are, what their worries are, what gives them strengths, what some of those abilities, if they were to be, if their illness was to progress, would they really not want to live without? What are some of the trade-offs that they're willing to make if they have to, if some tough decisions need to be made? So those get to really the values of the individual, and those are the things that can help the healthcare provider when they're having a conversation with a substitute decision maker about what has been important and what has been expressed. So I'm going to stop here because I wanted to leave some time for questions. I'm also very aware, and if I don't have any questions, I'm going to carry on, because I'm going to get into more around some questions that we've had with healthcare consent. And I don't want to race through those slides, but I want to give us an opportunity to answer any questions. So I'm going to just see, or you can put them in the chat. You can take yourself off mute. And I'm not able to see the chat. So if I could get someone from Sarah to let me know if there's any questions about.
Yeah, I'm keeping an eye on the chat right now for you, Jill.
Okay, so I'm going to move on quickly into some of the common questions around that might have to do with, or more likely to do with, healthcare consent.
There's one that, sorry, just came through in the chat. Did you want?
Okay. Can you, I don't have the chat up if you
Yeah,
could.
absolutely. So it's a question from Tamara who's asking, is there any type of education available for young people?
That's a great question. And nothing that I know that Hospice Northwest has done some education in schools, but it hasn't been around advanced care planning. But that's not to say that there aren't opportunities. So we have, in the past, there was actually a dialogue that was done at Lakehead University a few years back, which was a great dialogue where they were in the study and they had set up, it was kind of a fortune telling stations. And it was, I think, like a circus theme where you could go around. And then they had people at various stations that just had questions to get younger people thinking about advanced care planning. So that, and Hospice Northwest does have kind of their dialogues. I call them like dialogues in a box, where people can go in and you can get the whole kit of the dialogue from Hospice Northwest if you were wanting to host an event yourself using those materials. So that for me locally is the only thing that I'm aware of. And then nationally and provincially, I'm not aware of anything that really targets younger people. But it's a need. It should be, we should be talking about this in our school systems for sure. So this slide is really just trying to show the difference between understanding that the three terms, advanced care planning, goals of care, and decision making, where they start and how they're connected or related to one another. And I think it's just a good model to be having in mind when we're engaging in these conversations and what they lead to. So as many of you are probably healthcare workers, you recognize and realize that the Healthcare Consent Act is what we follow when we're looking for decisions and informed consent. So prior to any healthcare decisions, your healthcare provider must obtain informed consent. So this is the, from the last slide, you're in that last box of consent conversations. And it must be obtained by either the individual or their substitute decision maker if the individual isn't capable. And the only exception to obtaining informed consent would be in the case of a medical emergency. So to give informed consent, the individual has to be mentally capable, meaning that they're able to understand the information that is relevant to making the decision about their health care. And they also have to have the ability to grasp the likely results of making or refusing that decision. And as healthcare providers, it's up to us to presume capacity. So the individuals that we're seeking consent from, we are to be coming into that interaction with the presumption that the individual is capable, unless you have reasonable grounds to determine that the person is not capable. So you would need to know what the test of capacity is in that situation. And capacity it's not related to age, disability, or ability to communicate. And capacity is also a socio-legal construct. So it's not a medical diagnosis. So that when we're getting informed consent, it's coming from a legal context, not from a medical diagnosis. And capacity is not static, so it doesn't stay the same. Incapacity isn't static. It fluctuates and it can change. So every time the healthcare provider is assessing that individual's capacity or ability to consent. And who assesses capacity? This is a question that we often get, and it comes about around capacity assessors. So the healthcare provider offering the treatment decides whether or not the individual is mentally capable of making the decision. Admission to long-term care facilities, that's done through our home and community care support services. So that is a definite role when application for long-term care, that capacity is being assessed by them. But it is also around personal assistance services. So the kind of assessment is on, this kind of assessment is ongoing. It's not really necessarily a one-time event. As I said, every time you're proposing a treatment, if it's not part of a plan of care that's already been consented to, you would be obtaining consent. And it has nothing to do with our opinion as a healthcare provider as to the rightness or wrongness of the decision that's being made. Capacity only speaks to the quality of the understanding and the appreciation the individual has in making that decision. So the capacity assessors, they are fee for service, and whoever asks for the assessment pays for the assessment. So if they're in the hospital and the hospital or somebody on the team is asking for that capacity assessment, then the hospital would be responsible for paying it. You can get information about who are capacity assessors and how to find them by looking at the capacity assessment office or going to the capacity assessment office, which is located in the office of the public guardian and trustee. They're on Red River Road. And you can also find this information online under the Ministry of the Attorney General as to who can do capacity assessments. And then I just go back to the do not resuscitate, because this is one certainly that I think often gets proposed in what people think are advanced care planning conversations, but they really are consent conversations. And these orders can be challenging when there are maybe exceptions to a DNR. So for people who are writing out a plan or expressing wishes, they may have some exceptions as to when they would want to be resuscitated. And those forms may not capture that, those consent forms. So the DNR, the do not resuscitate certificates, the ones that many of us have seen, they have the serialized number up in the top corner. Those consents are really only directing EMS. Our levels of care forms that are commonly used in long-term care homes and some hospital settings, they can often be misguided and have really draw on misinformed practice. So it's really important to scrutinize those forms to see whether or not they fit within the Ontario legal framework. If you're just checking off a box of yes or no for do not resuscitate, where is that conversation being captured and how is it being recorded? Because it is part of a plan of care. So it is not a conversation in isolation, it is a conversation that's part of that individual's plan of care. And it's really important that that conversation is documented in the notes or the record somewhere. And it's not just a check off box. So I'm going to stop here and just see if there are any other questions related to the information that I just around healthcare consent.
Yeah, there was one from Michelle that came through in the chat saying, what would lead us as healthcare providers to ask for a formal capacity assessment?
What would lead us sometimes? So I know myself, when the very few times I've seen where a capacity assessment has been requested, it's been in long-term care. And it has been around the person who's wanting to be discharged. Actually, it was wanting to be discharged home. And the doctor was, really questioning that individual's capacity. They were very advanced in age, and there were a lot of circumstances around that discharge and the safety of the home and the safety of the individual when they are in the home, whether or not the decision to be going, if he was capable. So in that case, it was the doctor who determined, who was questioning the resident's capacity, and the assessor came in. But really, if it is, I'm sorry, I'm gonna have to try and look up that. If it's the healthcare provider has questions about the capacity of the individual with the treatment being proposed or the plan being proposed, I think it really is an opportunity for that team to come together and to talk about what's happening with that individual and what are the reasons for thinking that they're not capable, when we know that we have to presume that they are capable, and what are the risks to that if if we're saying that they're not capable, we also have to inform them that we've made that determination. And it's up to us to also inform them that if they want to appeal that decision, it is within their right to do so. I mean, it's a process of going to the Consent and Capacity Board, but that is the right of the patient. So I don't know if that answered your question, Michelle. I'm just going to bring the chat up again.
There was a comment by Chelsea. First of all, Michelle said, yes, thank you. And then Chelsea says, thank you, Jill, for this presentation. Great information and perfect timing for Advanced Care Planning Day. The social worker from Marathon Family Health Team and myself are speaking at a medical minute on CFNO, the local radio station, next week. So the info is very fitting.
Oh, perfect. Great. I'm happy to hear that. I've also had a question, as you mentioned in the introduction. I am one of we have 3 regional advanced care planning healthcare consent champions that are through Hospice Palliative Care Ontario in the Northwest region. The question is, how do I become, not an advanced care planning champion with Hospice Palliative Care Ontario? So I just put up the information here. There is part of the Speak Up Ontario portal does have some information around healthcare, advanced care planning, healthcare consent champions, regional champions. I would be very happy for anybody in our region or across our region that would like to look into this or become one. Certainly invite you to, when they open up their call for expressions of interest, to put in an expression of interest. It is a great process. There is a training component that is run through HPCO. So you put in an expression of interest. There's some 50 hours that is dedicated to being oriented to this. So there's some education through the e-learning modules that anyone can take now through Speak Up Ontario, as well as some assignments. Part of this 50 hours is you have a mentor. So in the Northwest, one of our regional champions would be asked to be a mentor if you were interested. You meet with your mentor as you're doing your assignments. There's 3 assignments, and the assignments are really just looking at things that might exist within your setting or within your community around advanced care planning or healthcare consent. It could be policies, it could be brochures, and then you kind of look at them and review them and compare them or do an analysis against whether or not they fit the Ontario legal framework. And then you would make your feedback as to why it does or why it doesn't. They have the template to follow, so it's easy that way. You don't have to think of all these things on your own. And then there are 3 assignments that are similar to that. And then you have a final, you submit those, you have a final test, and then you become a regional champion. And then I also had just the references that were used, wanting to let you know about National Advanced Care Planning Day, and then some of the sources for advanced care planning that aren't trying to sell you something. So the Ministry of the Attorney General for Power of Attorney for Personal Care and Finances, as well as the Speak Up and Coming Full Circle. And I also had a question that wasn't in this one that I wanted to respond to, and it had to do around being compensated. Or can you be compensated for a power of attorney for personal care? And so interesting, power of attorney for finances, there is compensation. And if you go through the power of attorney document, it does talk about what that compensation is. It can also be something that's discussed if you're setting it up through a lawyer. But there is not compensation for power of attorney for personal care. So they don't have that same remuneration as a power of attorney for personal care, interestingly.
It's Teresa Bowen here.
Yes.
And I just had one comment. At the very beginning, you stated how, advanced care planning Ontario is about a conversation. And I have had to be substitute decision maker on a few occasions. And I just realize how important it is to have those conversations, because when you're making those decisions, you have moments where you ask yourself, am I making this decision for me or for this person, right? You know, you sometimes have that struggle. So if you've had conversations, then you can be confident in making those decisions, I think, you know, and it makes it maybe easier to make the decisions. So yeah, we all need to have the conversations. I need to have the conversations with who I have as my substitute decision makers, who happen to be my children, but it's just really important.
Yes, thank you so much for that, Teresa. And I definitely I've heard that from people who have been substitute decision makers and where they haven't had the conversation, and then when they have, and anyone I've talked to in those situations have always said, oh, it makes it so much easier. Like, you're not having to, exactly what you said, when you're second guessing or you're thinking because you don't know what they would have wanted, or, you know, how to go about that. So it's the burden on the person having to make that decision. It alleviates that when we're able to have those conversations. So thank you for that. I know we're at time, so I want to thank all of you for your time today, and happy Advanced Care Planning, National Advanced Care Planning Day. And as we said, the slides will come out, and it will include within those questions, the slides with the questions, it will include what I said, the information or the material that responded to the question.
Thank you very much, Jill. That was very informative. And I think from the amount of questions we're still getting, definitely a topic that everyone, maybe I'll have to tell Steph we have to do a third one. I would also like to just let everybody know that coming up on April 27th, our next Sarah speaker series, which is aging among adults with intellectual and developmental disabilities. So that's a focus on frailty with Dr. Lynn Martin. So that's again, April 27th over the lunch hour from 12 to 1. I just put a link in the chat to the, but I have to actually hit send. There we go. To the Sarah events page where you can get registered for that. Or just go to sarah.lakeheadu.ca/events and check it out. Again, thank you very much, Jill. We want to wish everyone a wonderful weekend. And if, yes, you're in Northwestern Ontario, hopefully you can, hopefully you didn't put your shovels away yet. So,
So true.
thanks, everybody.
Thank you.
Bye.